Good evening. I want to welcome everybody to this last Sage's Dermpath Happy Hour of this year. Today, we're going to be doing a quick 5-case CPC. Hope you enjoyed the cases. If you have any questions at all, you can post them in the chat. Or if you're watching this video at a later date or reviewing it later, you can always email us at education@sagesdx.com. Happy to have you email me directly to my personal email, tdavis@sages.com. So without any further hesitation, we'll go ahead and move on to our first case, case number 1. You were given the clinical history that the patient was a 73-year-old male. He had a long-standing, fairly large 4.5 centimeter mobile subcutaneous nodule on the left upper back, and the clinical impression was that of a lipoma. And in this clinical image taken from the EMR, you can see this sizable deep dermal subcutaneous nodule on the left shoulder of this obviously older individual. And an incisional biopsy was performed, and one can see that we have a large, partially sampled neoplasm. I think even at scan, you can see and appreciate that the fact that the neoplasm is composed largely of adipocytes or adipose tissue. The adipocytes here are a little variable in size, but there are no lipoblast or pleomorphic cells identified. And then if we look in other areas, let me back out a little bit. And I'm going to get my pencil here. We can see that other areas are a little more cellular. And if we focus in on this area, what we see is a proliferation of fairly uniform cells. Some of them appear oval, but most of them are spindle shaped. And they've got a very even chromatin pattern. They're not particularly hyperchromatic, and we really cannot identify any mitotic figures. These are embedded within a slightly myxoid stroma, and then there are ropey collagen bundles present between the adipocytes and the spindle cells. A CD34 stain was applied. The piece of tissue up at the top is our control and our positive control. And then if we look in these more cellular areas, in the sections stained with CD34, we can see that these uniform spindle cells packed in between the ropey collagens are strikingly CD34 positive. And the constellation of findings in these sections, when coupled with the clinical presentation, are very characteristic of a spindle cell lipoma. Now, spindle cell lipomas, as you know, are typically solitary, very slow-growing lesions. They tend to occur in elderly men. Most commonly seen in men in the 5th to 7th decades, with a striking site predilection. They tend to almost always occur either on the back of the neck or on the upper back of shoulders. Not very common in women. And they typically have 3 components. They tend to be well-circumscribed tumors. And the 3 components that you want to see in a spindle cell lipoma are mature adipocytes, which we saw in this case, interspersed with these CD34 positive gland spindle cells, and a variable amount of ropey collagen. Now, in younger lesions, the spindle cells tend to be embedded in a more myxomatous stroma with numerous mast cells, and with time, usually one sees more deposition of the ropey collagen bundles. Clinically, spindle cell lipomas and pleomorphic lipomas, and histologically really, form a spectrum of adipose tissues. This is supported, among other things, by the finding of similar cytogenetic abnormalities, but the clinical presentation is almost identical. Both pleomorphic lipomas and spindle cell lipomas tend to present on the shoulders, upper back, or back of the neck of men in the 5th to 7th decades. And basically, if you take a spindle cell lipoma and sprinkle in the pleomorphic floret giant cells with overlapping hyperchromatic and pleomorphic nuclei devoid of mitotic figures, you have a pleomorphic lipoma. So they do indeed run along a spectrum. Now, one other point before we move on to case 2 that I'd like to make. Most soft tissue tumors we think of as having characteristic component parts. Again, here with a spindle cell lipoma, mature fat, the spindle cells, and the ropey collagen bundles. But you have to keep in mind that these tumors are not like homogenized milk. And so the component parts are not evenly distributed throughout the tumor. So if you section a large spindle cell lipoma, you can have areas that are quite cellular, almost all spindle cells with no to little fat, in which case we have a so-called low fat or fat-free spindle cell lipoma. Other areas might be almost all mature fat with few spindle cells or ropey collagen bundles, and other areas may have abundant ropey collagenous bundles and mixed with adipocytes resembling warm fiber lipoma. So you have to look at several areas, several sections to get a feel for any of these large tumors. Let's go ahead and move on to case number 2. Case number 2, the patient was a 38-year-old female. She presented with a firm papule on her left buttock, which was pink. And the clinical impression was that of nub versus irritated nevus versus DF. And in this clinical photograph, again, get my pencil, we can see this reddish brown papule, well circumscribed on the buttock, not particularly large. And a bread-loaf shape biopsy reveals a dome-shaped papule with a dermal infiltrate. The epidermis is mildly hyperplastic, and even at scan, you can see why this lesion was firm to palpation or somewhat indurated. The cellular infiltrate within the dermis is embedded within a very sclerotic stroma. Notice how thick and pink and sclerotic these collagen bundles are. We move to higher power, we can see that even though the epidermis is hyperplastic, it's relatively uninvolved in the process. There's nothing going on along the DHA. And when we go down and look at the cells in the dermis, we can see that these are strikingly epithelioid. And by that we mean, of course, that they have a low nuclear to cytoplasmic ratio. These cells have round to oval nuclei, a little bit pleomorphic, and really abundant eosinophilic cytoplasm. They resemble epithelioid histiocytes. Some of these, if you take a look, are actually nested. They form small nests within the papillary dermis. And if we take a look in the deeper dermis, we can see that the cells tend to break up into cord strands and solitary units in the lower portions of the dermis. There are no nests here, and the cells themselves are quite a bit smaller. The nuclei are smaller, less abundant cytoplasm. And again, you know, the mitotic figures were not readily apparent in these sections, nor is there much of a host response. Now, a dual Ki67 or MIB1 MART stain in this case revealed that these cells were melanocytes. They were positive with the MART, and the Ki67 revealed a very low proliferation rate. In addition, the cells were negative with a PRAME immunostain. PRAME can be a good marker to use for melanomas. And in this particular photomicrograph, let me zoom in, you can see that there was retention of, and we'll zoom in, P16 staining by the melanocytes comprising this proliferation. Here, many of the nuclei and some of the cytoplasm shows decoration with P16, which is a favorable marker in Spitzoid-like lesions. And so the correct diagnosis in this case is an intradermal Spitz nevus. Now, obviously, like any melanocytic nevus, a Spitz nevus can be junctional, it can be compound, which is what we see most often and which is what usually shows up on an examination, or they can be intradermal. And the intradermal ones, one has to have a fairly high index of suspicion for. Like most Spitz nevi, they do tend to be composed of enlarged, spindled, and epithelioid cells. They are frequently reddish-brown in color and firm. Histologically, as we've seen, they're characterized by enlarged, spindled, or epithelioid melanocytes, typically in a sclerotic stroma. They show little or no pigmentation. And as we pointed out, P16 staining is retained, and PRAME is typically negative. So this was just a real nice example of an intradermal Spitz nevus, which shows a lot of histologic overlap with a desmoplastic nevus. In a desmoplastic nevus, however, one tends to have a proliferation of smaller, more banal appearing melanocytes rather than the enlarged spindled or epithelioid melanocytes characteristic of a Spitz. But occasionally you'll see a tumor that's kind of combined with kind of a mixed population of cells. Case number 3, the patient was a 50-year-old male. He had a dome-shaped regular papule on the left anterior shoulder, and the clinical impression was that of a nevus. And you can see here on the shoulder, the clinician had dotted the lesion before injecting it. Dome-shaped papule actually bears quite a bit of similarity to the intradermal Spitz nevus that we just looked at. And indeed, I'm going to tilt the slide here. One can see that we have an infiltrate in the dermis here. This lesion has a very benign silhouette. The lesion appears symmetric and fairly sharply circumscribed. The epidermis is thinned with effacement of the reedy ridge pattern, and we've got this infiltrative cells in the dermis. Again, these are kind of embedded in a little bit of a sclerotic stroma. If we look at the edges of the lesion, both edges and in the upper portions of the lesion, we can see this population of very banal appearing melanocytes, cords and strands of cells. There's evidence of maturation with depth. These look like ordinary melanocytic nevus cells, okay? And you can see them at the edges of the biopsy specimen. But right smack dab in the center of this lesion, we've got kind of this syncytial mass of much larger melanocytes that bear striking similarity to those that we saw in the last case. These are very epithelioid. There's little, if any, maturation with depth or uneven maturation with depth. The nuclei are round to oval. A few are slightly hyperchromatic. Some of the cells are multinucleated. A few are pigmented, and yet there are no mitotic figures identified here or readily apparent. Once again, a dual key Mart stain looking at proliferation index and a melanocytic marker revealed that this lesion was indeed melanocytic, all of the cells stained with Mart. It had a very low proliferation rate, and P16 staining was retained. Now, clearly, anytime we've got two distinct populations of melanocytes in a melanocytic lesion, we've got a combined nevus. We can call it combined when there are two distinct clones or distinct populations of melanocytes. This combination with banal melanocytes flanking a large epithelioid nodule, as I'm sure many of you are aware, is very characteristic of a BAP1 inactivated melanocytoma, so-called BAPoma. And these lesions are characterized by loss of BAP1 expression, which is the protein product of a tumor suppressor gene in the more epithelioid population. And indeed, if we look at the BAP1 immunostain on this particular case, and I'm going to go ahead and zoom in, one can see that the banal population of melanocytes here at the periphery of the lesion are positive, as are most of the epidermal keratinocytes. However, if we look at the population of epithelioid melanocytes, look carefully at these nuclei, you can see that they are stone cold negative for the BAP1 immunostain. There's a little cytoplasmic blush, but BAP1 is a nuclear stain, and these are stone cold negative. Okay, so the diagnosis in this case is an intradermal BAP1 inactivated melanocytoma. In this case, there's no evidence of melanoma. We could call this an intradermal BAP1 inactivated melanocytic nevus. I like that term better than BAPoma because BAPoma makes it sound like the lesion should express BAP, when in actuality these lesions are deficient in BAP1. Most BAP1 inactivated melanocytic tumors are clinically fairly nondescript. They're usually reddish-brown papules, average diameter of about 5 millimeters. They can occur anywhere. They can occur in a broad age range, most commonly occur in the second or third decades of life. No sex predilection. And yet, despite the fact that they clinically are fairly nondescript, the histopathology is much more distinctive. As we've seen, they are frequently biphasic with two populations of cells, with the proliferation of these small nevoid or banal cells out of the periphery and the large epithelioid cells. And again, these epithelioid cells had abundant eosinophilic cytoplasm and haphazard maturation. There's usually a low mitotic index. And of course, the detection of BAP1 loss is integral to the diagnosis of BAP1 inactivated melanocytic tumors, whether they're sporadic or syndromic. And most of these also simultaneously harbor a BRAF V600E mutation. So take-home points. Now, most BAP1 inactivated melanocytes are solitary, and they're the result of sporadic mutations. If, however, one has a patient who's got two or more BAP1 inactivated melanocytic tumors, biopsy proven, or if they have a single tumor and a family history of uveal melanoma or mesothelioma, those patients should be referred for genetic counseling and germline testing because they may have the BAP1 tumor predisposition syndrome. As it turns out, this patient, after this biopsy was obtained, had two more lesions biopsied, one of which was a second BAP1 inactivated melanocytic tumor. So he's been referred for germline testing as well. So these are tumors, again, nondescript clinically, but a distinct histopathology. Moving on to case 4. Case number 4 was a 103-year-old woman, bless her soul, with a nodule on the left chin. The clinical impression was that of a dental sinus or abscess or basal cell carcinoma. And in this clinical image, you can see that there's an ulcerated draining nodule on the chin, some purulent scale crust on the surface. The shape biopsy, let me go ahead and tilt the slide here, was trisected. And what we see within the dermis, kind of embedded in granulation tissue here, is a large abscess. There's a large collection of neutrophils here in the dermis surrounded by granulation tissue and granulomatous inflammation. And if you looked at the top, you can see that what fell out of the dermis here was a very large grain, okay? And this grain, there's some neutrophils out of the periphery, so you can see this was sitting in this abscess, has some of this smooth Splendora Hopley phenomenon. And if we look centrally, we can see very basophilic areas here and kind of this paved matrix. Well, this is screaming for special stains, and a tissuegram stain reveals, let's zoom in here. I'm going to see if I can get us on a little bit higher power. Numerous gram-positive filamentous bacteria making up this grain. I think you can appreciate them in these sections. They were actually highlighted a little better with a GMS stain. So we'll zoom on in and focus in on the grain. And here, I think you can better appreciate these numerous, I'm going to zoom in a little, numerous filamentous elongated bacterial forms in the dermis. These were negative with AFB and bite and the PAS stain was inadequate. There was too dark to really interpret. So the diagnosis in this case is an actinomycetoma. Actinomycetomas, of course, are characterized by these fluctuant swellings, which frequently progress to draining sinuses. They do show predilection for the cervical facial region, as we saw here, but they can occur on the abdomen and in the thoracic region as well. Histologically, usually what one sees are large grains. Actually, they can vary somewhat in size between 300 microns and 2 millimeters. And these are usually located in the center of an abscess with surrounding granulation tissue. The grains, of course, exhibit this smooth splendory hoplite phenomenon at their periphery. And they're made up of gram, GMS, and usually PAS positive filamentous bacteria, which, unlike nocardia, are not as fast. The causal organism in most instances is actinomycosis israeli, and this is a very difficult lesion to culture. It's an anaerobic bacteria, and it can be extremely difficult to culture. Okay, let's go ahead and move on to our next case. Oops, sorry, I got ahead of myself. Case number 5. Case number 5 is a 35-year-old male. Unfortunately, no clinical images were available. The patient had a pink, slightly pedunculated papule on the right inferior lateral mid-back, and the clinical impression was that of nevus lipomatosis versus a neurofibroma. And in this in these particular sections, you can see that we've got a slightly pedunculated papule here. Within the dermis, there is a neoplasm which is vertically oriented and fairly sharply circumscribed, kind of has a pretty characteristic benign silhouette. And if we move to higher power, what we see are these lobules and kind of small nested aggregates of uniform spindled cells. Many of these have very elongated cytoplasmic or nuclear processes tapered on both ends. Okay, so these are extremely delicate. And again, these are embedded within a somewhat myxoid stroma. And hopefully the configuration of the nuclei here made you think about a neural tumor. This particular tumor was both S100 positive. This is a little out of focus, but you can see it picked up the stain. And the tumor also stained, this is a little bit of a cleaner immunostain, with SOX10. So you can see nice nuclear decoration of SOX10, and that combination of stains confirms a neural origin. I think you can actually even see the architectural configuration of this lesion a little bit better with the SOX10 stain. Well, these findings are diagnostic of a nerve sheath myxoma, which of course is a nerve sheath tumor. And as you're probably aware, nerve sheath myxomas also having been reported in the literature in the past as myxoid neurotheciomas. They're relatively rare tumors, excuse me, with a peak incidence in the 4th decade. They tend to show predilection for the extremities, particularly the hand and knee or tibial region, but really you can see them just about anywhere. They're usually solitary and slow growing, typically vary in size between 0.5 centimeter and 2.5 centimeters, multilobular and painless. They do have a tendency to persist if not completely excised, so usually we'll end up recommending a complete but conservative excision. And histologically, they have a benign silhouette, but they tend to be non-encapsulated and characterized by these multiple myxoid lobules that contain these sparse spellate cells that are S100 positive. This is a distinct distinction to the cellular neurothekioma, which, as you remember, is probably a fibrohistiocytic tumor and tends to be S100 negative. It can be S100A6 negative and S100A6 positive, but it's typically S100 negative, and again, probably a fibrohistiocytic tumor. Well, that's all I have for you now. And if anybody has any questions, please feel free to send them our way. And certainly wish everybody a happy holiday. Thank you.